Yeah, good morning, dear colleagues. Good morning, Chairman. Thank you, Felix, and your team for inviting me. It's not an easy topic, you promised me, to talk about clinical-based decision-making, but I put together some ideas that I would like to share with you. So clinical decision-making is a balance. It's a balance of experience, of awareness, knowledge, information, gathering, and using all the assessment tools we have, the evidence we have, the knowledge of your colleagues to guide you. The hypothesis is that pulmonary valve regurgitation, it's all about this. Interestingly, individual patients with the same degree of PR, they have a different extent of RV dilatation and dysfunction. It differs widely. So let's check whether this is really true, that it's all about pulmonary valve regurg and the consequences of that. MRI is the main method where people base their decisions on, and we have some guidelines. I hope you can see this here in this picture. I put together guidelines from the American Heart Association from 2008, the European guidelines from 2010, they are the Canadian guidelines, I think was also 2010, and then the Boston group gave some different advice as how to handle pulmonary valve regurg in the asymptomatic patient. We have to remember that it's the asymptomatic patient that the guidelines are made for. It's easy for the symptomatic, that it's clear, but if you look here in detail, you see the volumes. They are not very precisely denominated. They are called moderate, it's important, severe, but distinct numbers we have only in a few guidelines for the end diastolic volume and the pressure. This is obviously something that we can discriminate more precisely. There are the other values, the tricuspid regurg, it's ECG with a QRS duration, arrhythmia, and you're very familiar with all that. The guidelines, they have a low level of evidence. Besides the symptomatic ones that have a class 1, the level of evidence for the rest is B or C. Because most of you are from Germany, I want to pick only the German guidelines. They are you can read them on the homepage since 2015 by Übing and some other authors, and it describes the PVR is reasonable. It's reasonable, so there is low evidence as well, but in these guidelines, it's the MRI is a prerequisite, and then you have to have additional symptoms or RV dysfunction, RV dilatation, tricuspid regurgitation, and in these guidelines, we stick to the QRS duration or a progress of it. What about the transcatheter interventions? They are not within the guidelines. These guidelines I showed you, they are for the surgical cases, but there has been an advice from the American Heart Association in 2011 that it is reasonable to include this technique for RVOT intervention. And what about the trials where they used the transcatheter pulmonary valve, the IDE trial in America, the instructions for use? They didn't include volumes at all. So obviously there are different cohorts, one with a predominant pressure, residual pressure load, the others with the volume load. So do we chase the right targets? Here you see a lot of surrogate markers we think that might help us. But the current guidelines rely on retrospective studies mostly. There are small numbers of patients. The majority of patients, they were symptomatic, so in a late phase. They are established for surgery, as I told you, and TPVR is not considered. So we have to have guidelines not only for a short-term follow-up, but for a long-term perspective for lifelong outcomes for our patients. Let's talk about patient history. You see here the milestones of corrective or palliative surgery. And so we have different people. We have patients in the 70s and the 60s. We have the younger ones. We have patients with no surgery before. We have 2, 3 surgeries prior to pulmonary valve repair. We have difference in exposition to cyanosis. We have syndromic patients. You all know that there is a difference between patients who get pulmonary valve replacement after ROS, from those who have a fellow, from those who have pulmonary atresia, and those with Down syndrome are very different. What's the impact of the era of surgery? If you look at these numbers, that shows you graphs of patients corrected in the 1960s and after the 1980s. You can see that the improvement of the overall late survival was mostly due to the improvement of the early survival. Later on, there is not much of an influence. It's independent on when they have been operated on, and it's independent at which aid they are operated on. What about ECG, the QRS complex I mentioned already? We had ECG long before the MRI people showed us what we can measure in volumes and volumes and volumes. So the lengthening of the QRS complex has been defined as a surrogate marker for worse prognosis, and there has been set a cutoff line, and I showed you it's still valid in our German guidelines. There has been attempts to include this QRS duration within a risk score, but if you look here, the impact of QRS duration compared, for example, to non-sustained ventricular tachycardia, to end-diastolic pressure, is rather low. And if you look at this graph, you see that it is only a transient recovery, a transient reduction of QRS duration after PVR. If you wait, it comes back. And there are these cutoff limits. If you're more than 150, I would say you cannot expect normalization. But QRS duration does not necessarily mean that it's a surrogate for death. It just says it doesn't come back. But mortality is a different thing. So what about these volumes? I will not repeat, and we will have a talk about MRI later on. But after years of volume measurements, it turned out that it's more the function rather than the volumes that count. And it's not the PR fraction that predicts worsening of function, neither is it the RV dilatation. So it's more important to look at the ventricular-ventricular interplay. It's probably the most important predictor of symptoms in fellows. And we have these cutoff values of right ventricular ejection fraction less than 25 and less than 50% for the left side. There have been several investigations, especially came from the Netherlands, and a lot of meta-analysis checking or looking at the volumes. And what everybody proved is that despite regressing or decrease of volumes, in pediatric as well as in adult people, there is no change in right ventricular function, and there's no normalization of QRS duration. And the thresholds given, they account for normalization of the right ventricle size, but not for the function of the right ventricle. And important data came from the indicator registry. A huge number of patients were analyzed, and they took hard endpoints rather than surrogates. They looked for deaths, for sudden cardiac death, heart failure, and it turned out as well in their analysis that it's the RV-LV mass, it's the atrial arrhythmia, and it's the left ventricular function that puts the patient on significant risk for malignant VT or death. When we enter the era of transcatheter pulmonary valves, is it possible that we are better with this technique? I think the data are looking promising. From this paper, I got the analysis that the left ventricular function improves. There is an improvement in cardiac exercise, and there is a decrease of the end-diastolic volumes. And for every decade younger, the results get better. So it's the young patient where you can expect a decline in end-diastolic ratios of the right and left ventricle, at least for a follow-up of 5 years. I will not talk about echo, but this is, we use the echo as a screening tool. There are comparable parameters, the right ventricular fraction area change, some volume measurements that are comparable to the MRI results, but I think this is something very easy to do and gives you an idea whether there is restrictive physiology or not. It's this end-diastolic forward flow that tells you that there is some stiffness of the right ventricle and the end-diastolic pressures might go up and consequently the pulmonary regurg gets less, and perhaps there is less secondary right ventricular dilatation and remodeling. So is restrictive physiology something we should be scared very much? There has been an analysis of Frigiola, a lot of patients, and their phenotype was they are older than 35 years, they have a very good physical exercise. What do they have special that they perform that well? And it turned out that it's a moderate residual pressure load on the right ventricle, on whatever level. At the PA branches, the diameter of the annulus, or mild RVOT. And this was confirmed by other groups showing that in MRI, that if the surgeon leaves us with a moderate stenosis, it might be supportive for the patients. But when you look at these data that came from Boston, we have to be aware that whatever we do, whenever we do something, it's transient. The right ventricles will fail. The volumes will get up. The function will decrease by time. So whatever we do, it's palliative. And even if there is a small increase of pulmonary regurgitation on the long run, it has tremendous effects on the right ventricular function. So did we change the practice? There's some enthusiasm about intervening on the RVOT, either surgically or interventionally. There is the numbers increased dramatically, but we did not change the age at which we do this up to now. Coming finally to some questions of the patients. Will I feel better after you give me a new valve? How long will my valve last? Will I experience infection or reoperations? What about arrhythmia? Will I live longer after all? We have this data from London that showed that a sustained hemodynamic result can be expected in exercise capacity in the short run, but they will have a decline. And they found that those with some pressure load are the ones who might be more beneficial in that. We have the data from Munich. There was one paper in 2014, and they showed also a short-term improvement in either group, whether they have pulmonary regurgitation or predominantly pulmonary stenosis. And it was confirmed, I think this year in Euro Intervention, a paper that showed that this effect can be, at least in the measured as quality of life, can be sustained until 4 years after TPVR. So what about longevity of valves? To be honest, there is no difference. It seems that in this picture that there is a difference between xenografts and homografts, but we put in homografts more in small children, and when you correct this for age, there is definitely no difference. The risk factors that we have are age at implantation, extra anatomic position, and smaller implant sizes. We do not operate as early as we see the dysfunction of the valve. It comes later, but in fact it parallels the dysfunction curves. The same we have to expect in the transcatheter pulmonary valves. Redos are within the concept of transcatheter pulmonary valves, and you see the graphs here. The re-interventions can be surgically, can be percutaneously. Most of them are handled by transcatheter means again. Re-interventions, about 77% are for restenosis. 15% for endocarditis, only around 2% for valve insufficiency and other indications. So this is an analysis of what has been published, and it's about 4.4 re-interventions per 100 person years that we have to tell the patient he will be confronted with. What about endocarditis? There have been a lot of discussion about infections of the melody valve. There has been recently, this year, a systematic review, and what was the result? There is no difference in endocarditis between catheter-based and surgically implanted bovine valves. If you look at this bottom line, you see there is a difference between the homografts and the contragrafts. It was confirmed by several groups. Predisposing factors like previous endocarditis, RVT stents, turbulent flow, and so on have been quoted to increase the risk. So how can we approach to the RVT if we have dysfunction? I took that from a paper from Kim from last year. You assess the PR severity if there is moderate or severe PR. If there are symptoms, you go for either surgical or for transcatheter intervention. If right ventricular function is good, you can wait until you see dilatation, and then you will decide on whether you use the guidelines, whether you stick to numbers which should be very individually handled for every patient. So the actual guidelines, they focus on these follow-up years of the adults, of the patients aged 20 and older. I think what we can expect for the future is that the implementation of TPVR will impact on that. We will focus more on function than on volumes with all the newer MRI, echo, whatever techniques. And we when we talk to the patients, we have to be honest. We have to tell the patient of your own institutional experience, what he has to expect when he is operated or intervened at your site or wherever, because this might differ between the institutions. You have to respect the patient's environment, his personal preference. You have to integrate his view of what he wants to have done. We join it to make the decision, it's joining the dots. It's joining the evidence, it's joining your personal experience, the patient's interest for the best interest of the patient, with all the things we have in our toolbox. And I think it's not, I would not like to leave you disappointed with all the pictures I show you, but never give up and try to get new results, make your studies, continue in working, even if you are beyond the guidelines, because this will give us new information for the future. Thank you very much.